everyone. Welcome to the 5th installment of our Journal Club, a cornerstone event within our esteemed medical faculty research community, or MRFC. This event takes on a special significance as it's the first one organized by the new committee of the MRFC. Today's session will be conducted in a dynamic question and answer format. Your active participation is not only encouraged, but eagerly awaited. We will be delving into the insightful study titled Presenting Status of Children with Classical Congenital Adrenal Hyperplasia over 2 decades, 1999 to 2018, in the absence of newborn screening in Sri Lanka, authored by Dr. Sumulu Senaviratne. However, the true essence of today's session lies in your participation. It's not just about absorbing information, but about sharing your perspectives, asking questions, and contributing to a vibrant exchange of ideas. So let's make the most of this opportunity. Let's collectively explore, analyze, and uncover the insights within the article. Moving on to our resource person, it is my honor to introduce Dr. Sumulu Senaviratne, an accomplished professional in pediatric medicine. She is a senior lecturer at the Department of Pediatrics, Faculty of Medicine, University of Colombo, and an honorary consultant, pediatric endocrinologist at Lady Ridgeway Hospital for Children. With a wealth of research contributions, Dr. Senaviratne's expertise shines through, particularly in her role as a first author in publications in influential journals like Hormone Research in Pediatrics, Journal of Clinical Endocrinology and Metabolism, American Journal of Obstetrics and Gynecology, and BMC Public Health. Her scholarly dedication has not gone unnoticed, having garnered 3 research awards, including the prestigious President's Research Award in 2016. Dr. Senaviratne's interests traverse a wide spectrum, encompassing differences in sex development, child obesity, and the intricacies of endocrine complications in pediatric cancer survivors. Beyond her scholarly pursuits, Dr. Senaviratne's commitment to enhancing research communication is exemplified by her innovative introduction to bus stop talks, fostering an environment of knowledge exchange among students. It's worth noting that she has also played a pivotal role in mentoring our senior colleagues during their elective programs, resulting in international publications that bear witness to her mentorship. Madam, your presence here today is a true honor for us. We deeply appreciate your willingness to share your expertise and insights, and we thank you sincerely for gracing us with your participation. With that, I invite our very own Tharushi Angelika, the research coordinator of the Medical Faculty Research Committee from the A-Level 2018 batch, to lead us through the upcoming session. Over to you, Tharushi.
Thank you, Sandy. Thank you very much, everyone, for joining in on Wednesday evening. And let's start delving into our article first. So before we move on to the Q&A session, so as Sandy said, this is the article that we will be discussing today on our Journal Club. So the title is Presenting Status of Children with Classical Congenital Adrenal Hyperplasia over 2 decades, that is from 1999 to 2018, in the absence of newborn screening in Sri Lanka. And we are fortunate to have the main author of this article, Dr. Sumulu Senaviratne, with us to discuss this article with us. So first of all, I think I must ask this question at the very onset from Madam. Madam, please, can you share the process behind developing this research question? How the scene was set for you to choose this?
Okay, thank you, Tharushi. I think, so first of all, a big thank you to the MFRC for inviting me for this event and the kind introduction. So now this is a study we did, I think, in 2018, about 5 years back, and it was only published in 2021. So there was a little bit of gap. But I started my endocrine training in 2000. 11, and I had opportunity to see lots of children with this condition in Sri Lanka. And when I went to New Zealand for my overseas training, I had the chance to look at the experience for newborn screening for the whole of New Zealand over a 20-year period. So I had never thought of, how our babies present, because I took it for granted that they would present in a clinical state. But when I went to New Zealand, the good thing about their system was it's one of the oldest systems in the world to have started newborn screening for C-CAH. So one of the most long-standing countries, and there are kind of people who kind of provided guidance for many other countries. So it was a fantastic opportunity, and what they had done was, because I think in Sri Lanka and developing countries, we are not that good with electronic record keeping, but that's a big difference when you look at developed systems. They have electronic records, which then are very easy to go through. So I was invited to do this research by my supervisor to look at their experience over the 20 years prior to 2012 to see how New Zealand was performing with newborn screening. But when I went to do the research, however much you think, we found that the data was incomplete. So we went back to the good old system where each patient, we traced their BHTs, gave it to a kind of person who does the records, and I had to work in a record room. If any of you have ever gone to a record room in a hospital, well, it's the same. Huge bundles of tickets because they collect everyone's records in one number. They don't have different VHTs. So huge records, and I spent hours and hours in a room going through these VHTs trying to trace this data. Then I realized we can do the same thing in Sri Lanka, because at the end of the day, to get really good data, we needed to actually go back and trace it. So when I came back to Sri Lanka, I realized we have about 40 children. That was the amount we had there. And we have been having one of the long-standing services for C-CAH in the country, the only service which was available up to 2013. So Professor Shamya, who some of you have had the fortune of learning under, so she was my trainer, and she was one of the first people in Sri Lanka to ever start managing these children in a clinic. So we had data for 20 years here. So we extrapolated that this could also be a kind of large cohort, and we looked at almost the same outcomes in our children. So I used the experience of that research to do it in patients, and that's how the idea came across, because we don't have newborn screening, and I was interested how our babies vary.
Okay. And could you just elaborate on the broader recommendation that you hope to give to the Sri Lankan medical community at the end of this study?
Yes. So I think, and this is some guidance to you all as young researchers just starting out in the field. Sometimes I think some of you would have completed your community research project. Some of you may be waiting to take it up. It's kind of difficult when you don't have much clinical experience to think of a good research idea. So here, actually, because I was helping these patients, I needed to know whether many babies were dying. I really wanted to know, because we didn't have newborn screening. It was available for 30 odd years in the world, whether this would make a difference in our country. So I really wanted to answer this question to myself more than, first to myself. And then when after we found the results, then I was really convinced that this is something we need to start at least over the next decade or so. So it was a question in my mind that I really wanted to answer. So I went into great depth to make sure my data was accurate. I really wanted to answer the question, and I think found the answer to which satisfied myself, and which we then shared with the rest of the world.
I'm sure this was a very rewarding experience for you as well as you described to us. So before moving on to the Q&A session, first of all, I'll give you a brief overview of the article. So we sincerely hope that you had a chance to have a look at the paper, but if not, don't worry. We are going to give a brief overview of the article. So let's start. So we'll just start with the key points. The key points are explained under 3 main topics. Just to simplify everything, we'll just briefly describe what the question, what have these researchers found out through this study, and what does this imply. So the research question is very important to understand. So, and while reading the article also, we'll have to go back and refer to this question to understand why these certain methods have been used and what the discussion points are implied. So first of all, the question is, what are the clinical features at initial presentation in male and female children with classical congenital adrenal hyperplasia from Sri Lanka? So the focus of the study, the condition that we are focusing here is classical congenital adrenal hyperplasia. So I must say that for the benefit of the junior students in our audience, we will be giving a brief account of the pathophysiology, a brief introduction to C-CAH and the subtypes. So just stay with us. So the key term here is classical congenital adrenal hyperplasia, and the second one we thought is the clinical features at initial presentation. The researchers have researched into the initial presentation. They have collected data about the initial presentation of these kids. And the other one is they have done a gender comparison as well. So you may be getting questions as to why they have done a gender comparison here. So we are hoping to answer all your questions, and you are encouraged to raise any question. Okay. Then the findings I'll summarize very briefly. So in this retrospective Sri Lankan clinic-based study that included pediatric patients with classical C-CAH from 1999 to 2018, more than 80% presented with impending adrenal crisis, which is a life-threatening complication of C-CAH. So most of the girls, that is 96%, had virilized genitalia, while another significant percentage of them had uncertainty about gender at birth. So this is an issue that can cause many psychosocial issues in this kid's life in the future. So we'll be discussing about this briefly as we go on. And among the other features at the initial presentation were hyperpigmentation and consanguinity of the parents. And the median age at diagnosis was found to be 20 days, and males were diagnosed later than females. Nearly 3/4 of these children had salt-wasting C-CAH, which is more severe and unfortunately a commoner form of classical C-CAH. And the treatment of salt-wasting C-CAH was initiated at median age of 30 days for boys, as they were diagnosed later, and 10 days in girls. So what does this imply? So the Sri Lankan clinic-based study analyzed the clinical features at the initial presentation of children with classical C-CAH, and they have identified that most of these kids initially presented with life-threatening complications, and possibly some have succumbed to classical C-CAH undiagnosed. So therefore, both male and female children with classical C-CAH would benefit from diagnosis by newborn screening, followed by early initiation of treatment. So this is a very brief overview to the article, and let's move on to the Q&A session. So at the outset, I'd like to invite all of you to raise questions either by unmuting yourself and raising the question orally, or put up in the chat. So we'll be very happy if you can ask questions and share your perspectives, because your perspectives will enrich our conversation, and we all can have a very entertaining evening today. Yes, madam.
Tarushi, I was intrigued by this cartoon. It's really interesting. I think you put that for a reason, but I'm not sure I got the reason correctly. Is it for a very good reason you put that there?
I'm not sure I'm thinking of the same reason, madam.
All right. Shall we ask, can we come back to this before we wind up?
Okay, madam. No, can we direct that question to the audience? Do you think this cartoon was included for a specific reason? Please, guys, answer. This is a simple, funny question, just for fun.
So, would you prefer a tiger to eat you or a gorilla? And the answer is, I prefer if the tiger is the gorilla. Really good comeback. But it kind of made me think of something similar.
Please share
it. Hiruni wants to answer. Hiruna.
Sure, go ahead. Kiruna, please go ahead. I think it was by mistake, madam.
All right. I thought like the tiger and the gorilla were a little bit like, would you prefer to be a girl with CH or a boy with CH?
Oh, yeah.
And I thought I'd prefer if the tiger and the gorilla was if we had newborn screening.
Okay. We didn't think of that, madam. I don't think we are
Really
that much knowledgeable about CH as to make
It's
such.
not knowledge. It's not just like, would you prefer to be a girl or a boy? It's a debatable question when you look at it. And let's think about it as we go along. Thanks, Tarushi.
Okay. So mainly for the benefit of the junior students in our batch, we thought we'll start with the pathophysiology, the clinical presentation, and different subtypes of CH, because this study is particularly about classical CH. So let me invite Hiruna to brief us about the pathophysiology, different subtypes, and clinical presentation of CH. Over to you, Hiruna.
Can you hear me, Tarushi?
Yes, very clear.
Yeah. So about the pathophysiology of congenital adrenal hyperplasia. So it is a group of autosomal recessive disorders because of defect in adrenocortical hormone synthesis. So most of the cases, almost 95% of the cases, is due to a deficiency of the 21 beta hydroxylase deficiency. So if you look at what this is. So if you look at the pathway, the adrenocortical hormone synthesis pathway, it starts off with cholesterol. So the cholesterol molecule we all know. So this cholesterol molecule is converted to pregnenolone by cholesterol desmolase, which is usually activated most by ACTH and also slightly by LH, which is luteinizing hormone. This pregnenolone is then converted to progesterone by 3-beta hydrosteroid dehydrogenase. Also, pregnenolone is converted to 17-hydroxypregnenolone by 17-alpha hydroxylase, and at the same time, progesterone is converted to 17-hydroxyprogesterone by 17-alpha hydroxylase. Then progesterone and 17-hydroprogesterone is converted to deoxycortisone and deoxycortisol by this molecule we talked earlier, this 21-beta hydroxylase. So what happens because of this deficiency in 21-beta hydroxylase is this pathway stops. So deoxycorticosterone and deoxycortisol is stopped. So the production of corticosterone and cortisol by 11-beta hydroxylase is reduced. And also because of this, corticosterone can't convert to aldosterone by aldosterone synthase. So aldosterone also reduces, and also at the same time cortisol and corticosterone also reduces. Since this is reduced, what happens is the pathway to the right of this pathway increases. So what happens is 17-hydroxypregnenolone and 17-hydroxyprogesterone is converted to DHEA, which is a dihydroxyepiandrosterone and androstenedione by 17-20 lyase. So the production of these increases because of the production of cortisol, aldosterone, and cortisol is reduced. So like the body thinks that the body doesn't have enough cortisol and aldosterone, therefore by a negative inhibit the pathway, which I'll be telling in a couple of seconds. Because of this, the production shifts to the right. So because of this, androgens increases, and simultaneously by 17-beta hydroxysteroid dehydrogenase, testosterone and estradiol and dihydrotestosterone are increased. So if you look at the hypothalamus pituitary axis, what I was going to say was, so as you all know, the hypothalamus is there. It produces cortisol releasing hormone to the anterior pituitary, and thus it stimulates, it releases ACTH, which goes and stimulates the adrenal gland, which produces cortisol, aldosterone, and all this. So when there's a deficiency in this, by negative feedback, it gives a negative impulse to the, it gives a, so because it's reduced, because of the negative feedback pathway, it says the hypothalamus and anterior pituitary to secrete more of CRH and ACTH. So because of this, the pregnenolone and cholesterol, these molecules are sent more towards this pathway, but because those can't be produced, it will be going towards the right side, producing more androgens. So if you look at why the hyperplasia of adrenal gland causes, so I was telling about why it causes the production of more androgens. If you talk about why the hyperpigmentation occurs, it occurs because, so when there is a negative feedback stimulus, we are sending this stimulus to produce more ACTH. But ACTH is produced by a chemical called as POMC, which is pro-opiomelanocortin. So this produces this substance is used to produce ACTH. So this produce is also used to make another product called as MSH, melanin synthesizing hormone. So when the negative stimulus is sent, because POMC increases, MSH also increases. Because of the increase of MSH, there will be a hyperpigmentation. So then I'll be talking about the various subtypes and clinical presentations. So if you talk about the subtypes, so basically we can divide it two as classical CAH and the non-classical CAH. So the classical CAH is usually the one, the more severe one of the two, and non-classical CAH is somewhat milder than the classical one. So the classical one is usually found in infancy and childhood, but the non-classical one is usually found in adolescence and adulthood, and this is because the deficiency is of a lesser extent than the classical CAH. And the classical CAH is of two types: the salt wasting CAH and the simple virilizing CAH. Out of these, the most severe one is the salt wasting one, because it can cause the adrenal crisis, and because of the aldosterone, there is salt wasting because there's a loss of aldosterone because that pathway is blocked. So there will be more hypovolemia and more loss of sodium. So and it's going to go to adrenal crisis. The simply virilizing one is because of the excess production of androgens. So because of the androgens, it can virilize females, and for males also it can produce because of the excess androgens, which we'll be talking about next. If you can see in this picture, about virilization in CAH. So this picture shows a cryptogamy in a female, and also you can see the partly departed labia, and also another thing we see in females is a common urogenital sinus. So the other picture, if you can see, in this you can see a male. In here the penis is enlarged, and other than that we won't usually see any other signs at birth. And in this chart you can see that there is a precocious puberty, where there's an early born age due to the excess production of androgens. So thank you. Over to you, Tarushi.
Thank you, Hirana. Madam, would you like to add anything, or can we move on to diagnosis and management?
Yeah. Yes, sir. That's fine. If there are any questions, I'm happy to take them, or we can move on.
Yes, madam. So we are happy to entertain any questions from the audience regarding this pathophysiology and the varying clinical presentations. I guess most of our audience have not learned about it yet, as we have a lot of participants from 21 and 20 lectures. If you have any questions, please raise these questions, put up in the chat, because madam is here, and we are going to anyway learn this from madam, and today you have a chance to ask a question.
If anyone is confused, I can share some slide, just one slide. But if you're happy to move on, we can. Those who want a one slide description, raise your hands.
Yeah, please raise your hands if you want Madam to describe this briefly again using one slide that she has prepared. Please raise your hand. Just use the hand raising option. Yes, Madam, that's one person.
So then I'm going to leave this and move on to the other device.
Sure.
Can you allow me to share from this device? I'm sorry, I've logged in.
Yes, sorry. No, yes.
Sorry, my issue.
Can you share now?
Not yet.
I have to make it.
Same name. Thanks. Hiruna did a great job, but it's a bit confusing, especially if you have never learned about it. So what I would say is just remember this. This is the adrenal gland. It has 3 zones called GFR. That's how I remember it still, right? GFR. And the G produces, you can use color coding. Aldosterone, the middle zone produces cortisol. The lower zone produces androgens, the male hormones. Not only, male hormones are usually produced by testes, but the adrenal gland also produces a little bit of male hormone. So all females and males have a little bit of male hormone produced by the adrenal gland. So when you have 21 hydroxylase, the severe salt wasting form, you have deficiency of both aldosterone and cortisol, leading to hypokalemia, low sodium, hypotassium, low blood pressure, weight loss, and in association with the low cortisol, which leads to low blood sugar, low blood pressure, weight loss, dehydration, these lead to adrenal crisis. So severe salt wasting cause, you have deficiency of both those. And as Hiruna explained, the precursors build up and they are diverted to the androgenic pathway, leading to increase in testosterone, dihydrotestosterone, all of these, which cause virilization. So if you're a little baby boy inside your mother, and you're excessively virilized, that won't cause much problem, because anyway the baby boy is producing testosterone in utero. So it's a little bit additional testosterone, you won't see any difference. But if you're a baby girl inside a female, the mother is always a female, and you start producing these male hormones, then your genitalia gets virilized. And this process actually starts very early in life, from the 5th week of life. So these babies, the baby girls, are born with ambiguous genitalia, right? And these are the features which happen in later life if we don't treat them. But in the severe form that we're talking about, you have low aldosterone, low cortisol, and the virilization in baby girls. In baby boys, no virilization because it's not apparent, because anyway they are virilized, so they present later with this. So the tiger and the gorilla. On one hand, you have no features to pick you up, so you present with this. The other one, you have all these odd things happening into your genital area. Which one would you prefer? Okay, so that's how that joke came around. But I think that's in a nutshell. But we can move on.
Okay, thank you, madam. Madam, can you let me share the screen?
Yes.
Okay. So let's move on to the diagnosis and management of C-CAH, madam. So can you explain about the diagnosis and management of C-CAH? Because I think everyone is eager to gain insight into this, because then we can have a better understanding how to approach this article.
Sure. Shall I share my screen again then?
Okay.
Yeah. You won't be able to see me, but you can see my slides now. That's my way into another device. Yeah. So the management, can you see my slide?
No,
not yet. Okay, sorry.
Yes, madam, we can see.
Right. So the management includes, especially in girls, it includes
medical management in both girls and boys, but in girls, you also need genital surgery sometimes, and then a lot of psychosocial issues, and then now I'm really needing the need for transition of care from childhood to adult service. You can see some of these babies were born in 1999, so they are now 24. We can't hang on to them forever, but they don't want to leave us because it's been a long journey. So we have been transition care is also something very important that we don't talk about much in Sri Lanka. Yeah, right. So the slide I made for a recent, presentation. So it's just, you have to replace the hormone. So you have to give fludrocortisone is the equivalent of the mineralocorticoid, and the hydrocortisone is the equivalent of cortisol. So you need lifelong hormone replacement for these babies. And you have to monitor for undertreatment and overtreatment, which you will learn as you go along. But you will see in the study we have talked about virilization, we have talked about height. So some of these are features of undertreatment or overtreatment, right? So I'm so sorry, I'm talking to a different study. No, in these, but some of them are present with pigmentation, virilization, because they haven't been treated in utero at birth, right? And they can have hypotension. So this is the issue at birth. Some of these babies are long, like their length, birth length is more than 50, which is the average. They are 52, 53, 54, some of the very subtle features which you will see in the young age. So this is how the girls, we have this classification called Prada classification, and you can see, so normal girls don't have, they don't need a Prada score, but if you have a little bit of virilization, this is the mildest degree, and you may miss this if you are not really looking. All you see is that, can you see in the side view, the phallus, the clitoris is a bit longer, but otherwise looks like a normal female. But as you go along, then you see the labia is fused, the opening of the vagina is closing up. And in the fourth one, you can see it's like a little bit of completely fused. And in the fifth one, you even have like a scrotal form. Of course, there's nothing inside. This baby has ovaries. It's a baby girl. But you can see how long the phallus is. So this number 5 babies could actually be sent home thinking they are baby boys with gender misidentity at birth. And that's what we said. Or gender uncertainty. If you have a baby with genitalia of 2 or 3, the midwife and the delivery room house officer and the parents may not know whether this is a girl or a boy. So that is what we refer to as gender uncertainty. And gender misidentity is when they actually think it's a little baby boy and they go home. No testes are there, no one bothers to feel, and you have these issues. So this is the the tiger, the girl gets this, the boy doesn't have this. So what happens is they may go into adrenal crisis because they have no feature which can help to pick them up. And so we've done some studies on surgery in girls. Then they have issues in gender identity because they've been exposed to estrogen, testosterone in utero. So it has effects not only on the, so there are 2 main effects, one on the external genitalia, 2 on the brain. So they may have more boyish behavior. And the third thing is, if you don't pick up the low sodium and you wait for longer, we are seeing a lot of learning disabilities in our teenagers. Now, as we moving towards transition of care, we are realizing that the babies who are included in this study, I'm still seeing many of them. And none of them have done very well in school. And we feel this is an outcome of the very low sodium level that they were exposed to. And there's not much studies like this because many Western developed countries have now moved to newborn screening, so they don't experience that. So these are things which are common to countries which don't have newborn screening. And that's why it's a very interesting area to work on. So this is a girl, one of our patients, and this is how she is now. And she identifies very strongly as a boy. She is, it's a he. We are bringing this person up as a young teenage boy. So there are very complex issues. And finally, we looked at quality of life, but very basically, main thing is the medication and preventing adrenal crisis. Okay.
Thank you, madam. So I hope you guys understood that there are effective treatment methods, and identifying these babies is very important. So, madam, adding to that, can you tell us how CAH compared to other relatively more common congenital conditions like congenital heart disease or neural defects in terms of mortality, morbidity, and a little bit about the prevalence, local prevalence and worldwide prevalence, if there is any data regarding these things?
Yeah. So prevalence is a very interesting topic from a research point of view, Tarushi, because to actually give the prevalence, it's the number of patients with a disease in a particular geographic area over a particular, not over a particular period. Currently, the number with the total number. So in our unit, we know that we have 44 patients. But what about the rest of the country? We don't have. So how we know prevalence is it has to be notifiable disease. For instance, we would know the prevalence of COVID because it became notifiable at one point, and other communicable diseases we know. But if we don't have a notification system in the country or a database, then we don't know. So basically, we don't know what the prevalence of CAH is in the country. The worldwide average is 1 in 11,000, but it varies so much. So I was very surprised in New Zealand to see it was only 1 in 21,000. So much less half. And what we have now realized is that countries with consanguinity have very high rates because it's autosomal recessive disease. So a lot depends on, the consanguinity rates. And our consanguinity rate, I looked it up because we had to find it because I was interested in it. Does anyone remember? Anyone who read this paper very, very well might remember? It will be wonderful if someone raises their hand. Do you remember the consanguinity rate in the country which was quoted?
It was about 2%.
Excuse me, madam.
Yeah? No.
Among
madam, 7.4, madam.
Yes. And 27 also, yes, it was around 7%. And does anyone remember the percentage in this cohort? I think it was 14%. So it was higher, about twice. So that is why we think, right? So there are some. Now the thing is, so the question to this is, we don't know. And you might ask me, how do you know by looking at people who are living who died? So we can't know. But what we do know is that both these parents are very likely to be carriers of the disease. So we were interested to see whether at least in this cohort there were unexplained deaths. And we found a very high number of, so many families had a previous unexplained death of a newborn baby. So we are very, very interested in neonatal mortality, reducing neonatal mortality. But these deaths, until we asked that question, I don't think anyone had ever even thought that this is due to CAH or explained to them, except, from a neonatology or a general pediatric perspective. So babies are...
Madam, just to add to that, I think this lack of diagnosis is implied by the male to female ratio because we expect it to be 1:1 because this is autosomal recessive condition, but it is not.
Exactly. And it's striking, 2/3 boys and 2/3 girls and 1/3 boys. Again, something which was bothering me, and this study kind of, when you do a study, again, you can't really, these are things you extrapolate. Now, some of you might do a study, 40 patients, rare disease, and then just report the consanguinity rate is this many minorities, things like that. And you may not. So the thing is, if you have to have a really good question you want to answer. Here, I wanted to see, because I thought the boys would die, whether they were dying, and I actively looked for it. So you had to find ways to answer your question, and these were some of the ways that we kind of looked at it. So mortality is probably high, we don't know. But the important thing, Tarushi, about this question that I really like is, if your baby or if a child has a congenital heart disease or a neural tube defect, it's very much more likely to be picked up at birth, because we will auscultate all the babies, we will do a careful neonatal examination before hospital discharge. And the other thing is, most of our babies are delivered in a hospital. right? But if the boys are missed because they are asymptomatic at birth, and the girls are missed because people don't look at their genitalia carefully sometimes. And then the long-term morbidity and mortality is hidden, because these are not children who will go out to society and say, I have a disease, because it is something which affects their genitalia. No one likes to talk about it. No one sees it. No one knows it. In fact, sometimes only the mother and father know. No one else knows. They can't reach out to help. So it's really hidden morbidity and mortality. And I think that is why it's a different disease. There's a stigma.
Okay, so moving on. So I think our audience will be very interested in gaining a better understanding of the methodology of your study. So could you please share in detail about the research method, the research design, and how you thought that this is the most appropriate method to conduct this study, and the postulation behind the sample system, sample size. Can you elaborate a little on that?
Tarushi, the methodology is the key thing which makes or breaks a study. So I want the whole audience to criticize this. There are so many criticisms against the methodology in this study. And that is what you should be doing in a journal club. I know it's really complex for some of the juniors, so I'm really glad we went through the basics. But the methodology, I want you to criticize it. And I will defend it because it's a very simple methodology. And there's so many flaws that I want you to come out and tell me. Please, floor is open.
Please, guys, the floor is yours to present your perspectives. We are waiting for your...
Could we share the methods section slide?
Sure, madam. I'll do it.
Good evening, madam.
Yeah, good evening.
Madam, so my question is, this is a retrospective observational study,
Yes.
Which has gathered data which has been generated like up to 20 years back. So my question is, was the data was complete enough to get the data that is required at the current diagnostic methods for this study?
1 minute.
Yep, I'm back on video. All right. What do you think? You're not criticizing me, you're asking me. You should say this data is very old, right? Yeah, so that's the thing. So it's a very fair question that you question the validity of this data, and that's something that you should really, really do. But I'm going to ask you another question, and this is Mithun, right?
Yes, madam.
Mithun, how else can we do this? I want to know whether newborn screening is going to help our country. How else can I? One thing one country did was they looked at all the postmortems of babies who died. National postmortem whether anyone had adrenal hyperplasia, but I don't think that we might have so much detailed postmortem. Never looked at it. That's the only other way to do it. So I looked at other studies other research have also found this female preponderance as data. So we are looking at indirect evidence, and this was the only evidence which I could find. Now the reliability is, I mentioned it in the discussion. If any of you looked at the discussion, it is written as a limitation, but also we have put a counter argument to that. Does anyone remember Yes? Mithun, do you remember? The thing is, something very, very important, though we don't have electronic record systems, and today also in the board, I was teaching this to my trainees. If you record data very carefully in the book with times and dates and everything, and if you record it yourself, you're sure it's, so I'm 100% sure that Professor Shamya De Silva, yeah, here we go. So while this was a retrospective study, data was collected from meticulous clinical notes maintained by the first and last authors, and I owe it to Professor Shamya De Silva for training me to do this. So I was a house officer under her, like in the prof unit, specially trained in pediatric endocrinology, and I took over in 2015 since I finished my consultant training. And this data is very reliable because everything that, so I only looked for notes because I know Madam's handwriting and my handwriting, if it was written by a consultant, we took that. We didn't take notes written by registrars, and every patient had a consultant handwritten note. So we traced that. We didn't have to trace PhDs, which would have been very, very tedious in Sri Lanka. But this data is complete. The patients come to us. So we looked at all their old books, their old diagnosis cards, because we were most of the time looking at data from other centers before they were transferred. But this data was documented. So I know, as I told you, I wanted to answer the question for myself, not as a research, but personally. And I really, really believe this data is very accurate. And that's what I have written here. So you can take it or leave it, but I believe it. And that's the best that we could do under these circumstances. So my message to you is, if you want to really find the answer to a question, you have to do with what the best available data is. And that's a limitation of working in a developing country, right? Where we don't have, now, do you know the countries which have the most, fantastic health data, research data from? Mithun, do you know?
No.
Anyone else? So it's the Scandinavian countries, Finland, lots of very important research because they have fantastic record keeping for years and years and years. So they can find prevalence of anything, but many other countries can't. And this was the best I could do. So I'm still very happy that I did it. But I think you will find that many of you may be doing simple descriptive studies. This is a very simple descriptive study. It's also retrospective, right? So it's the special features that in the data that I think I can guarantee its accuracy. And I've written it because it's a very fair question that Mithun asked. But it got published in a good journal. So the authors, the reviewers believe that. So when you see a limitation, always state it and then state your excuses or your explanation for it. So we have addressed it, yeah, rather than not addressing it. Is that a fair answer, Mithun?
Yes, madam. Thank you.
Right. So research is not a clean, it's never clean. It's always unanswered question you're answering. So it's not answered because no one knows, because the answer is not very clear. That is why it needs research. So that is, if you do a research which does not answer a question, you're not actually doing a research. You're just duplicating something. Yeah. Yes, please.
So any more questions, guys? Any more such interesting questions which can ignite our conversation?
That was a very good point, Mithun, because that's the biggest limitation of this study, that it's retrospective data. And this is my comeback for you. You have to believe my word for it. and all the authors.
Excuse me, madam. Shall I raise a question?
Of course.
Yeah. Here the sample size is 40. So
yes.
Is it adequate for the statistical analysis? That's my question.
Yes. Is this Nadun?
Yes, madam.
Yes, again, very important question again. So, adequate for, I'm going to ask you what I'm asking you these questions because they're good questions, but I want you to really, really understand the question that you're asking. Adequate for what statistics?
Yeah, there is a minimum. There should be a minimum number of participants in the research, so that they can when.
Yes. Have you completed your community research project?
Yes.
You have, no? Yeah. So I know that, you know, and this, I mean, I did the same project as an undergraduate in the faculty many years back, and that's a fantastic, you know, research experience. So we also did 100 patients. You also would have done 100 patients, right? Most of you would be taking 100 patients.
Yes.
But the thing is, we can't find 100 patients with CAH, and actually you have to do a sample size. You know, there are certain research you do a sample size calculation, but the basis behind is that you don't waste your resources taking too many participants, and you can do it with a simpler number. I think many of us forget that. So here, this was the maximum I could get, and it answered the questions. I think the answers are here. Because it was so obvious, the gender predisposition. So if you actually look at it statistically, I may not be able to show it, but it's a clinical significance also. And you know that statistical significance may not actually reach a clinical significance. And vice versa. So statistical significance, lack of statistical significance might still be clinically significant. So that is why you need both people who understand the content as well as people who understand the statistics to work on it together. So when you ask me, was it enough for statistical analysis? I'm asking you, what is the question that you are asking? Exactly what clinical question? For prevalence? Is it for prevalence? For prevalence, it is definitely inadequate. So we didn't even try to talk about the prevalence, whereas in the New Zealand study, we calculated the prevalence. So the last 20 years, this is the prevalence because we knew it was a national newborn screening program where people were supposed to report back. So again, it depended on people reporting back to a certain degree. The clinicians had to report back, but they were supposed to do it, whereas here there is no such system. So for prevalence, we did not try to do it. But if we go to the results, Tarushi,
Yes, ma'am. Sure.
and I'm trying to give you a little bit of, you know, different ways to think about research, because I think you need to think, and it's a very good question. It's a question which, you know, many people asked me. But if you look at many of the studies now, at the moment, we are doing a systematic review on quality of life of children with CAH. We only found few number of studies. Most of them had 40 to 50 participants. That's a huge number with regard to CAH. And you can see we had only 12 males, no? So such a small number, but it reached statistical significance because it was so pronounced. The features were so pronounced, it did reach statistical significance. So I did what was available to me. I couldn't get any more, but I did find the answers that I was looking for. So don't let it deter you if it is the only sample which is rationally available to you. I know some of you want to do research, but because you don't have 100, you don't do. There's nothing like that in research. It is what you want to answer. So it's definitely not prevalence, right? But I found the answer. What are the presenting features? So when I say 70%, and how do I know? When I compare my data. So in the discussion, you have to go and we find. So I know Australia has 70%. They don't have newborn screening. We found 70%. So we are finding very similar situations in countries with newborn screening and without newborn screening. The more I compare my results with other limited data available and I find similarities, I am convinced myself that this data is accurate. And that's how you do it. Okay, don't let anything deter you. If you want to find the answer to a research question, there's always a way to do it. It may not look perfect in other people's eyes, But if you really defend your question, read around it, and try to understand it more, you will understand that many national studies have this number. Because I published the New Zealand study we published in JCM, which is the Bible of pediatric endocrinology. That's the most accepted. And they published 40 patients. I was convinced I could publish this, right? So actually working in New Zealand, I did my PhD there, was fantastic. And one message I really want to give you as budding researchers and undergrads, it's wonderful how then your society is popularizing research. It's wonderful how interested many of you are. I have published so many articles after that where I'm the senior author, and the first author is an MBBS graduate from our faculty, either voluntary. Some have not been my research assistants, but they have published. This is very good research. So you are very good. You are able to do. You just need a little bit of guidance, and the community program is superb. But you don't have much exposure to how to publish, and that's the beauty of this journal club. You really need to analyze what has this person done to make it this. Just 40 patients. That's what I would have thought as a medical student. Just 40 patients, all data, and how has she got this in an international journal? So it's a thought process. It's the effort which goes into it. And all the students who published under me, they put in a real lot of effort. I guided them. They put in a lot of effort. The more effort, the better outcome. So that is, how you kind of build it. You have to have a good question and the best methodology you can. This is the best I could. It would have been ideal to have national data, but I can't. Thus it got published, because this is the situation in many countries throughout the world. So again, two very good questions. I hope, I know we are a little behind time, Tarushi.
Yes.
But happy to take any questions, or we can move on.
Yes, any more questions? Because this is the most crucial part, as Madam said.
Madam, I have a small question.
Yes, Arnaja, please.
Madam, at the end, after doing this research and looking at all the data, on a personal level, madam, what's your take on the topic? Do you think when it comes to the Sri Lankan context regarding the clinical condition, that having a newborn screening program like we have for hypothyroidism in Sri Lanka, is it when you consider the cost and benefit ratio, madam, is it really useful in the Sri Lankan context?
As a pediatrician, definitely. No one wants to lose, and as a mother, right? As a parent, no one wants to lose a child who had the ability to live almost near perfect lifespan. We are spending so much money on, long-term survival of children who are sick with cancer, with prematurity, with heart disease, and we're forgetting these children because they die silently. So definitely, any life of a child saved. Imagine the productive years we are losing, probably good 80 years. You just need hydrocortisone, fluticasone, that's all. Very cheap. I mean, compared to the cost of other diseases. How many, heart bypass surgeries are we doing? How many strokes do we rehabilitate? How many smokers develop lung cancer and do we spend? So I think from a pediatrician, I'm not going to, any life save. Leave no child behind is the, kind of theme that we go through. And these are children. I really feel for the families who have lost a child and then have another child surviving perfectly well. They may not realize it. I don't tell them, but I feel, oh my God, they missed a sibling, right? Who could have survived. So my experience has been extremely, I think we should, but I know, it's not the time. Unfortunately, COVID came. So this was published in 2021. COVID came, and then the economic crisis came. So I'm not talking about it. We don't have 17 OHP for our patients, let alone to do newborn screening. We are really, really struggling. But I do have some messages, and that is if you see a family who are marrying their cousins, right? First cousin marriage, or even second cousin marriages, or especially if you are from an ethnic minority group where you have a lot of marrying within the family, within the extended family, within the same small cohort. I think it's really worthwhile spending the money to get a 17 OHP done for a newborn kid. Right? So that's my take home. And we forget the private sector because, but, if you yourselves have a baby born one day, I think it's worthwhile doing it. I shouldn't talk about personal experience, but, things aren't perfect and things are missed. So one day I'm really going to fight for this. And one day we will have it. Probably there's a really good, so definitely. And I'd like to, tell you that there is a NGO called CLAN. Now they have supplied us with hydrocortisone and fludrocortisone for 6 months for many of our patients. That's a huge thing because it's not available. And one of their main goals is universal newborn screening, and I shared this paper and they were so happy. So I'm going to speak at the European Society for Pediatric Endocrinology. They are having a global forum now, and research like this is really, really valuable. When I presented the newborn screening data in New Zealand, just after that in Australia, as a senior registrar during my training, they thanked me. They said, "Thank you so much. We are waiting for this data. Our Australian government is not giving us money to do newborn screening." And these are the pediatricians. So I think as pediatricians, as pediatric endocrinologists, we need to fight for it. Always there is so money is always limited, especially in a developing country. And I don't think we don't have money for medicine and testing for those who are living. We can't fight for this right now, but definitely over the next 20 years, we should start. So maybe some of you will be the people who work with me on this. I hope I have convinced you, right? So papers are the first thing, research is the first thing towards making a policy change. You can't go by your clinical If I just say my patients, their siblings have died, no one is going to listen to me. I have a publication. We have the data. When it's ready, we have this data, right? So that's the take-home message. Definitely, it's worth it if we had the money. We don't have the money.
Thank you so much, madam. Madam, also on a side note, madam, now given the current context, is there any research evidence, madam, on the sensitivity of clinical methods in detecting congenital adrenal hyperplasia on presentation?
I miss one word what about clinical presentation, detection and
sensitivity of clinical methods, madam, like examination and ability of clinicians to detect.
Yeah, so that is if you have a Prada one, you should be able to pick it up if you are trained. So this is something that we are doing a lot of awareness about. I have done something for Family Health Bureau. I've worked with this. I've done a presentation for the College of Obstetrics and Gynecology. So I'm now doing, I think we should have something for medical students, because when you are an intern, when a baby is born, you will examine every baby. So your batch, 1 year will be 1/5 of the interns in the country, right? If we can tell all the interns, make sure you look at the genitalia very, very carefully. That is one big way. So you don't miss any girl. Lots of girls have been missed at birth, lots. Then the boys, the message that I will tell you when you come to your prof unit is that if a baby comes with sepsis, they are vomiting, they are sick, they are dehydrated, you won't think of C-CAH, you will think of sepsis. This is how all the boys were treated. They were all treated with IV antibiotics for sepsis, but they had hyperpigmentation. See, you can see in this data how many had hyperpigmentation, how many, so vomiting, and if you did the electrolyte and the sodium was low and the potassium was high, you should think of C-CAH and you should do the 17-OHP. And if it is, you give IV hydrocortisone, the child will die. If you don't, the child will live. If you don't, the child will die. So yeah, there we go. So many of them had severe hyponatremia, right? Especially the boys. So I want you to be aware about this condition. And we have the data in our patients now. So you know how many, so it's good to have this data because because there's a different experience from my experience. I'm sure the interns, the medical students in New Zealand don't get this experience because many of them are detected. If anyone is interested, please look at the data from the other article which was published in the JCEM on newborn screening in New Zealand. And you can see almost very similar. So I use the same format for this. You can see screen detected, clinically detected, and how asymptomatic those babies are. right? So your experience as medical students in Sri Lanka is very different to their experience as medical students in New Zealand. You must be very, very vigilant. And it's your vigilance, it is your observation skills, and it's your knowledge. So it's my duty to educate you all. And it's not that difficult if you're conscious. It depends on how careful you are during your newborn screening and your sepsis.
Thank you so much, madam.
Okay.
Any more questions on the study methods? So I think we can move on to the next section of our discussion, that is on results. So one important thing that we need to consider about study results is whether these study results are concordant with the previous studies, or are there any disparities? If so, what are they? So I invite people to present the disparities that we could find between this current study and the previous similar studies. What did you find?
Yes, Tarushi, there were some facts that I found after reading the research paper. The clinical evidence of the initial presentation of the most of the around 82% of Sri Lankan population has presented with the impedance or wasting adrenal crisis. The similar number of initial presentation of solvent wasting adrenal crisis was there in the Brazilian and Saudi Arabian population as well, slightly low in Saudi Arabian population, around 50%. Similarly, more than part of Sri Lankan children were presented with severe hyponatremia at the presentation, and as similarly in the Sweden population, it was around the same number. But the important striking feature was the time to diagnosis and treatment. When we can compare about the other countries without the initiation of newborn screening for congenital adrenal hyperplasia, we could observe that relatively Sri Lanka, as a country without NBS, had a lesser days of time to diagnosis, like around 15 days. In compared to Brazil, it took more than that. Even the some states of United States had a more longer period to diagnose. And it was very, very strikingly seen in the countries with the NBS, where they diagnosed this condition very sooner, like in Sweden and New Zealand. And as someone mentioned earlier, as this is autosomal recessive disease, the male to female ratio are expected to be 1:1, but this female preponderance tendency was seen in other countries such as Australia, Finland, India, Brazil, and Saudi Arabia, and Syria as well. But conversely, equal gender ratios were more apparent in countries like Sweden, New York, Brazil, especially after commencing the newborn screening. And other important discrepancy I've seen in this study was the higher representation of children from ethnic minorities. If we take this study, around out of the 40 children we diagnosed, only 50% was Sinhalese, and there was 30% of Muslims and 20% of Tamils. Possibly due to the higher rates of consent. This pattern was also seen in Middle Eastern and South Asian regions, such as Saudi Arabia. So those were the main facts that I would like to point out related to the concurrent results with the previous regional international studies.
Thank you. Madam, would you like to add anything to this?
Yes, that was a very nice description. Thank you for that. So, but there is one word of caution. So you mentioned, and I think we've also kind of alluded to it in the study, that the Brazilian, I think the presentation was later than ours. But there is a I'm not sure about the details. I can't remember the details of the Brazilian study, but there is a little bit of a pitfall. I want you to think, audience, and tell me that this may be a biased study. A biased study, right? When you look at, before we are complacent that compared to the other nations without newborn screening, we are doing better. There is a bias in this. Who can tell me the bias? Think about our study population, our setting. Remember, they were referred to us from local hospitals.
Please feel free to unmute yourselves and give answers. Don't hesitate to unmute yourself and share your answers with us.
I am telling that this may be little bit, if we took national data, this data may not be this good. Why is that? You are, yeah, yes,
Madam, that as they have referred by a local institute, they can say that they have already screened through the procedure for the congenital adrenal hyperplasia. But when taking the national level, there are children who haven't still screened.
And they would have died?
Yes, madam.
Probably. They may be managed by local hospitals.
And because of the setting, madam, they have been referred to LRH, which is the largest tertiary care hospital for pediatric conditions. So here we are more able to diagnose these conditions because we have so many experienced clinicians. So the diagnosis has been...
Yes, Tarushi. So yeah, so some of them the diagnosis was not confirmed. Some of them the local pediatrician had confirmed it, or some of them had called for advice. So these are patients where someone was vigilant in all these centers and they picked it up and they called for advice. So there was someone in that unit who had a high degree of vigilance, who called for help and then transferred. So we have a little bit of a bias there. And also these are the patients now 20 years down the line, these are the patients who continue to come to us. You know, so we don't know whether this is not really representative because it's a selected cohort. So the presenting features were pretty bad, but at least they were picked up and referred and co-managed with a tertiary care center. So once which maybe the general local team managed, maybe it was diagnosed later, possible, right? Again, could have and still survived, but we don't have the long-term outcomes. So I think there's a little bit of bias there. It's difficult to really pinpoint it. I think that's a limitation which we did not deal with because we don't have much data. It's just from experience, I think. But what had happened is that many babies were treated for sepsis and then the sodiums are low, potassiums are high, and they kind of, at certain points, they picked it up. Right. So, yeah, there may be other babies who have also fallen out from our study over this time. Yeah. So I don't know. But yeah, that's an important question.
Any questions on that topic? Audience, you can raise questions. So, in the absence of... Madam, you're muted.
Sorry. So I hope this is interesting for you. It's been a long session. It's more than an hour now, but
yes,
I'm happy to stay on.
Thank you very much.
Yeah, I really hope you gain something from this. And if you have any questions, just feel free to ask, or if you want to move on, we'll move on, Tarushi.
Okay. So finally, I think if you can briefly summarize again why this classical CAH is an ideal candidate for newborn screening and the potential challenges and the pitfalls in implementing this newborn screening CAH, madam, because this is the recommendation.
Yes. So can you hear me?
Yes, madam. We can.
All right, Tarushi. So I think there are a lot of important things I learned from this study, which I am now teaching you all. Right. So actually, the newborn screening recommendation was more for the world. We want more data to support newborn screening. There are opponents. You might think, why is UK not screening? Why is Australia not screening? Because there's a high false positive rate, extremely high, because any sick baby, preterm baby will have what you call a fetal adrenal, and they'll be secreting a lot of precursors, so it will be picked up. So preterm babies, low birth weight babies have, then you call the parents, you get them back, you do another test, you say this might be a severe disease, and then, and then actually it turns out to be nothing. So that really increases the cost of recall and all that. And then the other issue is some people say, okay, the girls can be picked up clinically, as one of you all said. How about, so one thing that I am kind of doing on my own is trying to give you some data on, and so I'm very happy we did this, because more awareness raising on CH, so that we don't miss the ones who we can pick up. The pros are, of course, it's going to make a difference, right? We have very good pediatricians. We have now endocrinologists developing. We have adult endocrinologists. We have now availability of medication. We have subspecialties. So if these children survive, we are doing a lot for them. But the survival does not depend on us. The survival depends on all the healthcare professionals in this country, including midwives, and interns who pick up these babies, right? As well as the pediatrician. So at every level, we need to educate them. And I think right now, because we have such good, domiciliary healthcare services, that's probably the best way for cost effectiveness. The cons, as I told you, is high false positive rates. You need sometimes 2 tire tests. Like, you can't do just the immunoassay. You have to you need higher machines, better machines to do this. Then, of course, because we have a newborn screening program, and the blood test is, if you all have seen, they collect the blood onto, from the heel prick onto a blotting paper, and they post it to either MRI or Karapitiya University, which started the newborn screening for CH, and they're actually doing 17-OHP as well. So you can pay, parents can pay a little bit of extra amount if they're sending it to Karapitiya and get the 17-OHP done as well. But it's not only the cost of the blood test, it's also recalling, record keeping, retracing them, making sure they're traced. It's a huge, huge. And CH, the problem is they are screening before discharge. When you consider CH, you can't screen them before 48 hours of birth, because they will have I-17-OHP. So that's a huge issue. In New Zealand, how they do it is, for all the diseases, the midwife, many of their deliveries are at home, actually. It's midwife driven. They don't have such high hospital. I'm not advocating this at all for our country, but that's how their system works. And so the midwives collect and they send it on day 3. Whereas we can't do it on day 3. We are going to miss lots of babies. So there are practical problems. And that's a huge issue for us, for the normal deliveries. And then, of course, the cost. So the cons are those. So can high clinical suspicion and neonatal screening in the field by public health sector be an alternative? Definitely. That's what we are working towards, right? Early detection by clinical means, higher vigilance and high risk screening. That's what I would recommend. So I would really love to, I was speaking to my colleagues in some areas where we feel that there may be pockets of CH, because we have a lot of patients, ethnic minorities, consanguinity, those areas, whether we could start with those. I actually spoke to Karapitiya Hospital as well, but then COVID came, problems came, and we're doing so much damage control over what happened over the last 2 years, and then the economic crisis, that it's not a priority right now. But when things settle, hopefully it will be. So definitely you guys can make a change. You may pick up a child, you may save a life. So thank you for this opportunity to share these insights with you.
Thank you.
And thank you for your interest. We are very happy. I've created a center for hormone research. I've been working with volunteers, elective students. We've been doing wonderful work. And many of them have been, I try to put them to the forefront because we need to empower you people. So anyone who wants to do the elective with me, do volunteer work with me, I'll be very, very happy to work with you all and help to empower you all. That's why I did a PhD, not for myself, but to bring back that lovely research culture from New Zealand to here. They have a fantastic research culture, lovely. And journal clubs, these kind of things are superb. I'm so happy you guys are doing it and wish you all the very best. And happy to take any further questions.
Thank you very much, madam. I think so many of us in the audience are so much inspired. And any more questions, guys, to wrap it up? If you have any more questions, please raise them. So in the absence of questions, I think we can reach the end of our Q&A session. And over to you, Sain.
All right, Tharshi. And that brings us to the end of the 5th edition of our journal club, orchestrated by the medical faculty research community research community. Madam, do you have any other additional comments you'd like to talk about regarding the session or any feedback that you have from your end?
I really enjoyed it. I like to feel my audience, so it's a bit sad even. I'm glad you can see my face, but I can't see the audience. And I really want you to enjoy research, right? Enjoy it. Remember, you have the ability to be good scientists as well as doctors, and research often drives policy. So sometimes it's a clinical thing. If you see something which doesn't sometimes strikes you odd, that's usually a good clinical question. Right? So be alert for even the juniors, if you're in first year, second, as you go to the wards, before you start your community attachments, always be alert for some nice research. Because if the research question interests you, that is very important. You have to feel passionate about your research project. It must be something which excites you, that will give you that, that enthusiasm to carry it forward to a publication, because you have a message to give others. So try to find good research questions, right? It's something you have to develop over time. And I'm really, really happy to see. I learned so much during journal clubs. My very first journal club that I went for was in New Zealand when I went for in my mid-30s, right? But every week we had a journal club with our endocrine colleagues, the consultants, the registrars, senior registrars, and we would hack that research, take some random research. You can't do that with me around. I won't allow you to, but we would just, break it into pieces and say, why did they do that? We think we should have done it like this. So, you really, really develop your research know-how by looking at good research and, seeing, and even bad research, and see why it's bad. How can we do better? So I want you to, that's why I wanted you to criticize it. I'm going to defend my research, but feel free to criticize. We need to take criticism as researchers. This is all for, science. All right. So thank you very much.
Thank you. Thank you very much, madam, for the feedback as well as the lovely advice. As we draw the curtains on this session, I'd first like to thank again Dr. Sumla Senaviratna. Your expertise on congenital adrenal hyperplasia has undeniably been the cornerstone of today's enriching discussion. Your insights have helped deepening our understanding and improving collective knowledge regarding. Thank you very much, madam. And Tharshi, your skillful moderation of the Q&A session has been pivotal in making this interaction dynamic and meaningful. And our diligent organizing team and the entire medical faculty research community, your commitment to scholarly exchange has provided a platform to explore ideas, challenge assumptions, and expand our horizons. And finally, a sincere thanks to each participant who engaged with enthusiasm, driving the discussion to new heights through your questioning and insights. Your presence has made today's event all the more meaningful. Thank you very much. Have a lovely evening.
Thank you, madam.